Thank you both very much. So we'll take just a few questions, and we might try to get one case in real quick after this. I think Dr. Linos made a very important point about adrenal biopsy. There have been several studies that have looked at this, published it. Typically, it comes up in the setting of an adrenal incidentalloma, and we are still seeing patients who are biopsied before they're referred in. In some cases, it turns out pheochromocytomas are being biopsied before they're referred for surgical evaluation. And just to emphasize what a dangerous scenario that is, those patients can develop hypertensive crisis and can even die from that. So please encourage you to, the adrenal biopsy is also non-informative in that setting, so avoid it for the primary adrenal lesion. You can sort it out with your biochemical testing and with a careful review of radiographic imaging studies. Comments from the, yeah, Dr. Nant.
Can I comment on the biopsy? You should not even do it for metastatic disease. So here's the thing. If the patient is disseminated everywhere, you don't need a biopsy to tell you. But if that's a solitary metastasis, you want to remove it. Now that is one place you should do it laparoscopically.
Right.
And don't do the biopsy.
Very good comment. I have a question about presentation. There have been advances in imaging with high-resolution CT scanning with an adrenal protocol that improves our ability to determine malignancy perhaps preoperatively. And secondly, there are certain presenting patterns that also heighten the suspicion for malignancy, and I would appreciate your comments on those two points, please.
Well, the biggest problem that you have with, for example, incidentalomas that are non-functioning, because the ones that are functioning, you're going to take it out anyway. The problem is that the disease, the adrenal cortical cancer is actually very, very rare. Incidentalomas are very, very common. So whenever you're taking out incidentaloma, you got to be thinking, am I taking this out for cancer or not? And if you're taking out for cancer, if you think it is a cancer, you have to do an operation like what Dimitri have shown you, which is not just the tumor plus adrenal, not just that, plus everything around it, all of the fat around it and all of that. The problem with a lot of the preoperative study is that I'm sure all of them are going to suffer the same problem of false positives because you have a very small number of cancer.
Yes,
if I may continue what was just said, and I found it just reviewing this data is that, yes, it is true, the larger the tumor, the more chances of that being cancer. But if you do have a large tumor, still it's more likely to be benign. I review Dr. Dust and your tremendous experience from a past paper, and I saw the large tumors, and again, the majority of them were ganglioneuromos or benign. So we should remember that, and of course we have to resort to surgery, but if you have a large tumor, this is not going to be most likely a cancer. Unless preoperatively, and we're not talking about these tumors today, we do have local infiltration or of course metastasis or lymphadenopathy. As far as the removing the lymph nodes, that I think still remains a question. There are not significant data to prove that you have to go after lymph nodes. Lymph nodes what? Lymph nodes
Dimitri,
where?
you just showed me the German data that you
Right.
showed, and that's the same series.
What I was trying to tease out also is that beware of the young patient, less than 40, that has a large tumor that's making that's hyperfunctioning, particularly if there's more than one hormone that's being produced. That is a malignancy until proven otherwise, irrespective of the imaging features.
Dr. Linos, you raised the issue of the retroperitoneal approach and showed a very beautiful video taking out a pretty normal-sized looking adrenal. It must have been an aldosteronoma. So what are your size criteria for using the retroperitoneal approach? And the other issue that we face, retroperitoneal, in North America is the obesity problem. And as the patients get over BMI 35 or so, it gets more difficult.
I think it's an indication to go retroperitoneally. You imagine the fat guy with the belly, the adrenal is in the back. So it's much easier to put it, upside down and go straight rather than go through all the abdominal fat and organs. So I think it's an indication when you have an obese patient to go from the back. Now, he implied that if we have a 7 centimeter or 8 centimeter tumor, we have to make an incision 7 or 8 centimeter. That's not true, because these tumors are pliable. So you put them in the sac, so you don't have any spread of the cells, and you can just extend and you can remove it. In fact, Dr. Du is probably the first one that taught us that we can maybe remove it. I don't do it, but it usually comes a 7 or 8 or 10 centimeter very easily through your standard incision. You can extend it to 2 centimeter. The only risk from the posterior approach that hasn't been somehow brought up is the risk of injuring the nerve and have this hernia forever. That's a problem, and we have seen a number of cases. I don't know what's the percentage, 5, 6, 10%, but this is a disadvantage of this approach.
Let me ask the other panelists, what, say for a 4.5 centimeter unilateral tumor, transabdominal or retroperitoneal approach? Dr. Herrera.
Yeah, I think the retroperitoneal approach is a very nice approach, very straightforward, and it's good for small lesions. At the beginning, it was a concern that pheochromocytomas may not be retrieved with the posterior approach due to extensive manipulation, but the experience has proven that that's not the case, that most pheochromocytomas that are small in size can be retrieved through the posterior approach. I mean, I would be concerned in lesions that are either suspicious for malignancy or large. The space is very limited. So in the case that they presented a 7 centimeter tumor, I mean, I couldn't do it from the posterior approach because I think that space is going to be very limited. We're going to struggle with the tumor. And although malignant tumors could be excised through the posterior approach, if they are large, the likelihood of breaking the capsule is higher. In my hands, I think those tumors are better extracted using the lateral approach if we are trying to do it laparoscopically or with the open technique.
Just real quick comment, Dr. Ye and Dr. Sipperstein.
I would do a lateral transabdominal approach. I don't know the posterior approach, and I think the lateral approach is it's got a big working space, it's extremely versatile, and you can do it very quickly.
I'd favor the posterior approach in tumors up to about 6 centimeters. In any case, except for your small aldos, it's important to do an en-bloc resection, not just skirt the tumor.
Well, are there any questions from the audience?
Let's see. Yes, we have time for maybe one question.
Yeah, one last question from the audience, Barry.
The question, and I'll add a question to it for our two adrenal presenters. The intraoperative features that might concern you from malignancy. So Dr. Linos mentioned that a laparoscopic is approach if the principles of surgical oncology are preserved. And the challenge is that if you violate that capsule, then it's too late, like Dr. Du mentioned. So what features is it during the operation that can heighten your sense of malignancy? Dr.
Please
Linos?
try to keep your answers concise.
I think
we need
fracturing the capsule has been the main problem with open. And that's why I said a sensitive to the adrenal pathology surgeon. We had in the past recurrences for Cushing disease because people were not very sensitive to remove it completely and no-touch approach, essentially. And I think this is basic for benign and malignant tumors. Now, if it's hard and you cannot laparoscopically, you don't feel safe, then again, it's not, it's the correct way to convert to open. So I think laparoscopic, again, is another technique, another tool. You can eat your food with chopstick or with your spoon.
Short answer, Dr. Du?
When I do it, I make sure I see the muscle the vena cava, the kidney. If you don't see these things, you are not taking out all of the tissue around it, just like the picture there shows. And if you cannot do that, it means there's a lot of inflammation, and invasions tend to have some inflammation to it.
Well, on behalf of myself and Dr. Brunt, first I'd like to thank our presenters, particularly our international guests, and we'll let LA, that's pretty far away too, so thank you very much for coming, Dr. Ye. And we'd like to thank you for attending this session. We hope you found it educational, and we wish you a good afternoon. Thank you.